Venugopal, who has worked in various dimensions, various situations, and he has come out successfully with all these cases. Just 1 minute. We'll just give one small tour of Kim's Hospital, Karat, one small video, and then we come to you, sir. Sir is already waiting for us. Just 1 minute, sir. Various dimensions, various situations, and he has come out successfully with all these cases. Just 1 minute. We'll just give one small tour of Kim's Hospital, Karat, one small video. He is from Russia. He is my very good friend. He is a neurosurgeon from Russia. So this was a very beautiful tour of Karat. Sir has conveyed the best wishes to all of you for your achievement, prayers. Sir has given the best wishes, and he wishes that you all of should come and attach to Karat. Sir has invited all of you to Karat to see the facilities, to get associated. And now we'll be coming to Dr. Venugopal. To introduce Dr. Venugopal, he needs no words. His works speak of his abilities. He has done most wonderful things, whatever we can see in neurosurgery. He himself is a legend, performing more than 4,500 surgeries. And as a surgeon, so as a human being, he has a very golden heart. And from this golden heart, he has done a lot of charitable work and supporting a lot of poor patients in neurosurgery. You ask any surgery in neuro, and sir is capable of doing it. I was just scared, sir. Can we think of epileptic surgery in Kim's? Sir said, oh, epilepsy. Nothing worry. Shastri, we can do it. I said, sir, it's a large meningioma tumor. Can we work with it? Shastri, what are you speaking? Just a small surgery, patient will come out. I was just saying, maybe the era which we are living is a beautiful era, where such legendary neurosurgeons are there, where most legendary neurosurgeries can be performed. And I'm very happy that Dr. Venugopal sir is with us, a person of great humanity, great touch. And that is what I say, he is having a Midas touch. Any case he touch, you will see success and no deficit. When I met sir in Kim's, sir explained me everything what was going on. Some things I was not missing, I was missing up. He brought me next to me and he said, Shastri, see, this is the approach. This is the surgeon is thinking, and this is how we can evacuate the tumor. Sir is having infinite patience, infinite capabilities. He is himself a gospel of Bible. Whatever work he has done, only a Bible is a parable of Bible, I can say. The more I speak, the lesser it becomes. In Hindi, there is एक शायरी बोल के I'll just switch over to the show to sir. एक कलम मैंने लिखना चालू किया था, अनगिनत कागजों से शाही चलती गई, कलम लिखता गया, आगे चलकर कलम भारी पड़ती गई, कागज खाली रह गए, फिर भी अफसाने बढ़ते गए और दिल के गुमा थमे नहीं और सर की गाथा चलती रही। सर की अनंत गाथाएं हैं, एक एक सर्जरी सर की अनंत गाथाएं हैं। गाथा, आई डोंट नो सर इफ यू अंडरस्टैंड हिंदी और नॉट। गाथा मीन्स ए लेजेंडरी वर्क व्हाट सर हैज डन। सर की अनंत गाथाएं, एक एक गाथा सर की अनंत कहानी कहती है। हम एक बहुत बड़े सौभाग्यशाली लोग हैं कि इस इरा में हैं जहां सर ने you are able to witness his legendary work, and I can only say I am really obliged to you, sir, for sparing a Sunday time to us from all your busy activities. You have taken out this schedule for the benefit of this common people, common human being, and sir has given a very beautiful offer that together you come with sir and publish your international publications. Go to France, go to Germany. Sir is always very positive for academic work. Sir is very positive for surgical work. In every part, sir is very positive. I just request all of you to get associated with sir and publish your papers. Go to France, go to Germany, go to US, go to the best universities. And sir is always saying there is nothing for impossible. I always say everything is possible. Sir's beautiful tagline is what? Impossible says, I am possible. Shastri, let us make things possible for the new generation and new era. And this is where I introduce to Dr. Venugopal. Over to you, sir. Please carry on, sir.
Right. Thank you. So can you see my screen?
Yeah,
Yes, sir.
we can see your screen, sir. Brain and spine problem, sir. Right, sir.
Yes. Okay. So yeah. Good morning, everyone. So though it is Sunday, I'll because of Shastri, everybody is interested in academics. And I'm very happy that you people are very much interested to advance your academic careers and to be in advance with latest technology and to see what is happening in and around your place and in and around India. Okay, can you see? Okay. Can you see my screen? Technology and to see what is happening in and around. Yeah. So I'm a neurosurgeon who has been almost like 16 years experience. I'm from Hyderabad. So after that, I have done a lot of research in skull-based neurovascular, then in minimal linear spine surgery, neuroendoscopy, and endospine. So this is our hospital where it is there in the central part of Hyderabad, which is in the southern part of India. Now I'll just give small introduction about what exactly is a neurosurgery. So this was the early neurosurgery which was done in the Johns Hopkins University. It was done in the early hours of the morning because they used to depend on the sunlight. Otherwise, it was all dull. Otherwise, they could not operate it. And he is legendary Cushing, and he's Percival Bailey doing a temporal lobectomy. And he is the one. This is how the OTs used to look. Now, if you see the OTs, and it's very different. At that time, people used to have only these X-rays, and they used to do this. The patient was completely put in this kind of position, and they used to do X-rays, inject air into the spinal cord. So then we used to get these pneumogram chairs. And once we do this X-ray of the skull after injecting air, this is the kind of shadows we were getting. So at that time, there were no CT scan, there were no MRI. So people used to lurch in these shadows and find out what is this, where is this, what could be the tumor, where could be the tumor. Then they used to do exploratory craniotomies. So these are kind of X-rays, the angiogram they used to get, they used to think this is a tumor blush. Then this could be a tumor. Then they used to do a craniotomy on that side. And they used to inject spine myelograms to find out whether it's a disc or a tumor or it could be extradural infection or something. So that is the reason all these things were there. But now what happened was, so now you see, if at that time, if you see the kind of instrument the neurosurgeon was having all these things, but people are really getting scared because what kind of is it surgery or is it a butchery? And if you see here, things have changed. Like and here you can clearly see Uh, you can see that patient was put in a prone position. They were doing a trifine here, and they used to put fingers and used to take the tumor out. Like, see the kind of tumor instruments they have. So good that at the moment things have changed a lot. Now, what you have seen before, and we also have a similar setup here. We have a high-end microscopes, MRIs, then we have a neuronavigations, intraoperative neuromonitoring, so different kind of views from the microscope. This is a robotic arm, and this has completely changed the way we look at this exoscope, which we have recently seen. So looking at all these things, the neurosurgery has changed. Now it is no more scary to get operated. And because of this, we need microsurgical training because people have to not direct before operating on the patient. We really need to get trained under the microscopes so that it becomes easy for the surgeon to operate without any fear. That is very important because we cannot directly operate on the patient. So that is not even, though we are super specialized, again, there are multiple subspecialties in neurosurgery, like neuro-oncology, cerebrovascular surgery, endovascular neurosurgery, then skull-based surgery, spinal surgery, stereotactic and functional neurosurgery, minimal neurosurgery with vision endoscopy and minimal invasive spine surgery, pediatric neurosurgery, epilepsy surgery, movement disorder surgery for Parkinson's, dystonia, essential tremors, and psychosurgery for depression. So many surgeries are there in neurosurgery. Patients should not believe that it is only head injury or some strokes or some tumors. We have entire gamut of so many things are there which people need to understand. Unless if your primary care physicians know that these are the things which a neurosurgeon can do, then he will also know where to send the patient. So a lot of things have changed in the theater, like with relation to the navigation, we have stereotactic, frameless and frame-based, high-speed drills we have QSAS, and we have a microscope, 3D CAMs, SWAMs, intraoperative ultrasound, intraoperative CT, intraoperative MRI, and intraoperative neuromonitorings are there. And the brain suite is there as we have seen. And here again, ROSA. ROSA is robotic surgical assistant. So it will help the neurosurgeon just as you've seen the robotic arm moves here and there and it will hold the instruments. It becomes easy. So now let us, usually brain tumors, we'll see some of the brain tumors which are seen here. Usually we classify them into benign and malignant. Benign are meningiomas, dermoids, epidermoids, osteomas. Malignant are low-grade gliomas or high-grade gliomas. So this is a general classification. Now let us see more into some of the cases. A 45-year-old female presented with episodic headaches and one episode of seizure. And she did not have any focal deficit, but fundus papilloma due to raised ICP. So she was planned for surgery after explaining all the pros and cons of the surgery. So we did a right frontotemporal craniotomy and gross visual excision of the tumor was done. So this was the tumor was here, and following which we have done a post-operative. We can see this is the kind of tumor which we get. So the tumor was almost the size of the cricket ball. It has been completely removed, and the patient was got better. You can see the whole tumor has been cut here, and the whole tumor has been bone has been replaced, and there is no more tumor seen here. Then another lady with 48-year-old male patient complaining of headache associated with blurring of vision. And he has the status epileptic at the presentation. And after controlling seizures, we planned surgery. So for him also left temporal craniotomy was done with initial ligation of middle meningeal artery, then planned for the excision of the tumor. So you can see a large tumor occupying the left side of the sylvian, going from here to here. From it's occupying entire the whole temporal lobe has been lifted up. So such a large tumor has been seen, and the whole tumor has been completely excised. You can see the way the tumor has been changed the bone. Multiple bones have been formed here in different parts. You can see the thickened middle meningeal artery, the way it has made a groove here. So all these things you can see. 59-year-old female with decreasing hearing in left ear since 4 years. And she had facial numbness in the left half of the face since 1 year. Swaying while walking since 9 months, with blurring of vision since 3 months. And she, on examination, she had papilledema and left side sensorineural hearing loss was there. Nystagmus, gross left cerebellar signs were positive with dysmetria, dysradikinesia, pendular jerks. So following which we have done the investigation, and here you can clearly see this is the posterior fossa. You can see the large enhancing lesion in this posterior fossa, compressing and pushing the cerebellum, at the same time pushing the pons, with the distortion of the fourth ventricle. And here also you can clearly see. So it has, and if you see in the coronal cuts, you can see the size of the tumor. This is the tentorial margin. And the whole tumor has been pushed down. The cerebellum has been pushed to the opposite side. The patient has been completely, was not able to stand and walk because of this. So following which we have operated, we have completely removed the bone here, we have entered, we have completely removed the tumor. This being a benign tumor, the patient will be much better, much safe, and he will not have any major issues in the coming on to the future life, because it is not a cancer, it is a benign tumor. So once it is operated well and the tumor has been taken out, the patient will live a normal life and will have a good quality of life. And another, as we are in metro city, a lot of international patients come to us. A 45-year-old male who's an African who's operated in their local country. And they said because of the massive bleeding, they couldn't control the tumor. So they have left the tumor. Half of the tumor has been taken out. And later, the rest of the tumor has been left over, and the patient had multiple problems. So following which now he came to us, our country, with multiple episodes of status, and he's being in bedridden. So here, if you see here, so this is the part of the tumor which you can see gradually. This is the axial sections of the MRI. You can gradually there you can see the whole tumor has been significantly enhancing, and you can see the whole sinus was involved. The superior sagittal sinus, everything was taken out. And if you see here, if you see this part of the thing, you can see the kind of bone has been completely elevated here. If you see, this is a normal skull calvarium, we call it. And here the tumor has been growing up, and it has completely lifted the whole bone here, and it has gone up entirely. So you can see the tumor has come into the just below the skin. This white color is the skin, and the tumor has eroded the bone and has entered, it mushroomed into the whole scalp, taking away all the blood supply from here, and it has completely pushed the whole brain down till the level of corpus callosum. So when he came to us, then with this complaint he came. Now this is what this is a post-operative, the extreme right one. So here you can see the whole tumor has been excised, and there is no more tumor left here. You can see the whole superior sagittal sinus, everything we have excised, and because of the thing, the patient got better. You can see they are the intraoperative images. You can see here we have the whole tumor, the images, the central part showing we have put the pins, we have opened the whole scalp. And here, at the same time, the second image, you can clearly see where the bone after we have taken on. The first one shows the only we have removed the scalp and the tumor has been exposed. In the second one, we could see the left one, we can clearly see the craniotomy was done. The whole tumor has been exposed, the bone has been removed. This is a lateral view of the tumor where we can clearly see the whole tumor was bulging out. You can see the normal level of the dura, you can see the bone, and then gradually you can clearly see the how much tumor has been bulged out. So this clearly says the kind of pressure the tumor has been inside. And this is the right side is the tumor. You can see the kind of tumor we have excised. And the left side is the whole bone which has been removed, because usually in meningioma the whole bone also gets involved. And because of this involvement, again, if we keep the same bone, the patient will have more recurrences. So that is the reason we always tend to remove the bone if it is a secondary recurrence, because usually they tend to have meningioma cells inside this bone, and they will start having recurrences. So this way, once we remove this thing, the patient is almost fully cured here. Another important thing is some patients do come to us with massive headaches and sudden onset of severe headaches. There we usually call them as subarachnoid hemorrhages. In subarachnoid hemorrhages, when we expose the inside, we can see these kind of watery bleb kind of things on the blood vessels. So they are the ones which usually rupture. So when they rupture, usually the patient will have severe headache, thunderclap headache. The most severe kind of headache any person can experience is a subarachnoid hemorrhage headache. So there we can clearly see and find out where exactly the aneurysm has leaked, and following which we are trying to go and put these aneurysm clips. So once we do that, the patient will have the bleeding will stop, and the patient usually recovers faster. For example, Joe Biden, who is a American president now, he had two aneurysms. One has bled, following which for which he got operated. The other one he got it coiled, because two things we can do. He can be both done coiling as well as clipping. So here, when we are doing this coiling, usually in India, it is much cost effective when compared to clipping. If you do clipping, we it goes to somewhere and all these things. So here, these are the scan which you are able to see here. In the scan, we are able to clearly see this is the right side aneurysm clip. This is the way it appears. This is the way it disappears, and gradually, once we clip the aneurysm, patient will get faster, better. Another place is where we have another 25-year-old female who was doing her own job, following which she got pulmonary tuberculosis. When she got pulmonary tuberculosis, she was put on ATT. So as you know, all the drugs of ATT is isoniazid, ethambutol, rifampicin, pyrazinamide. When she was also, as she was already taking ethambutol, everybody labeled her as ethambutol toxic, as you can see in the slide. She has gone to ophthalmologist, and they saw she as her vision is less on one side, and they thought that it is more of ethambutol toxicity, and this could be the reason. But when they came to us, then she was not looking like that. So we got her in MRI done. MRI revealed, as you can see, there's a large tumor situated in the anterior part of the brain, skull base, which is compressing the optic nerve. So because of which her vision was significantly brought down. So we had done operated, and these are the post-operative scans. We have completely removed the whole meningioma, and patient usually recovered her vision almost normal within a span of 1 month. So this clearly tells us that if a skull-based tumor is there, people need not worry. They can come to us. We can clearly see, find out, and operate. So that gives a good result to them. Otherwise, the patient will become blind. They will not have a good quality of life. And here again, you can see another 49-year-old female who came to us with a massive tumor in the left cerebellum. As you can see, the whole tumor was enhancing, and it is again pushing the whole brain, posterior part of the cerebellum up. The tentorium was involved. So because of this involvement, patient was not able to walk. She had been having this complaint since almost 4, 5 years, and she knew that if she going to get an MRI, she will have some trouble. She may need to go for surgery. So because of all those anxieties, she never got it done. So in view of this, but when the was having repeated falls and she started falling down, then the family said that nothing to be done. Then they brought the patient to us, and we got the MRI done. MRI revealed this large tumor, and we usually do these kind of tumors with the help of intraoperative neuromonitoring. And here you can clearly see all the wires which we have attached to preserve all the low cranial nerves and the facial nerves and the cerebellum, as well as the low cranial nerves significantly, because if you damage those things, the patient will have significant swallowing or deglutition problems. So in that way, the patient quality of life will be compromised. So usually we put all these wires to preserve all the cranial nerves, to see that they are already preserved. So that way we can go there and do a microsurgical excision with the help of this neuromonitoring and navigation with the help of this high-end microscopes. Now on the post-operative scan, you can clearly see the whole tumor has been taken out, and is a reservoir. She did not even need a shunt. So this says that because the tumor was blocking the CSF flow, she was having headache and at the same time significant problems. Now the whole tumor has been taken out, and she will live a long life. So that way, the patient after surgery, the patient was very much happy, saying that yes, because of the tumor has been complete, now she can live a she lead a functional long life. So now her anxieties have been decreased. Another important thing is you might have heard something called as awake craniotomies. Like when the patient was conscious, patient was talking, we operate. So when do we do that? So patient think that how do we do that? So let us see some of the cases what we have done here. So eloquent cortex is the cortex where we usually are the places where important functions of the brain are there. For example, because if you remove them or if any damage happens to them, like we lose the speaking ability or the linguistic ability, we will stop losing the motor function or the sensory perception. So these areas are very important. If we directly damage them, patient will have a major neurological deficit, which will cause a significant debility to him, and he will become a kind of burden to the family and to the society. So these kind of eloquent areas, we really need to find out where the tumor is, and based on that, we really need to work on it. So they are the precentral gyrus of the primary motor cortex, primary sensory cortex, or supplementary motor area, or perisylvanian area, medial occipital lobe, along the medial temporal lobe, and the thalamus, basal ganglia, internal ganglia. These are the ones usually come under electron cortex. So if any tumor in and around are located, it is better to operate under awake craniotomy. So otherwise, we will end up damaging those structures and causing permanent deficit or damage to the patient. So we really need to classify them before. So ideally, who should be doing it? Specifically, when we have a speech area, hand area, wherever it is there. So we need to localize, and based on that, we will decide. So why? Because in the brain, it is not just like a white mushy matter. It is has significant wire connections inside. So how do they look like? So they have, based on the device, have been divided into different parts: media, lateral, middle, and aslant. So now let's see. So this is how, even though this is a normal MRI we can see, but inside the MRI we can map those fibers. This is the way the fibers appear. So when these fibers appear, so this is how the things are there, and gradually we can see that this is what the whole fibers looks like. And this is the way this lateral IFOF looks like. And then next comes the cingulum and the corpus callosum. And from here, anterior to posterior, you can clearly see the circuits. And this is the radiation of or occipital lobe, fronto-occipital fasciculus. Then you have multiple fibers. When we look it in the MRI, so we will be able to know what it is. And Aslan tracks are the one which usually help us in speaking. So this is when we superimpose all the fibers. So we'll be able to see different tracks inside the brain. And gradually they keep on. We can map them. As we know the tumor is in and out of the tracks, we can clearly separate them and go and take it out. And we need a good neuroanesthetist, because he is the one who keeps you informed about what is happening to the patient. He initially anesthetizes, then he wakes up the patient. The patient becomes more conscious. And gradually, as we see here, these are the things which a anesthetist gives some kind of drugs. Initially, the head pins, when we are placing, he will give some in the drugs. Then skin incision, he anesthetizes the skin. Then at the time of brain mapping, he awakes the patient. Then again, when we are closing, he will give little sedation so that it becomes easy for the patient. So after the craniotomy, you usually anesthetize the dura, because the dura is a pain sensitive area, because it is supplied by the trigeminal nerve, not by the superficial nerves, because it is deeper inside. As we cannot directly anesthetize, we are going to anesthetize the point where we are going to cut the dura. And these are the important things which usually as part of major surgical thing we use, but we need a kind of cortical stimulation or NIM eclipse usually we use. So here patient is exposed, electrodes are placed, we will map the thing, take the tumor out, achieve hemostasis, then again make sure that the patient did not have any major deficit. So this is the routinely things done. So this is a kind of image which will tell you. So this is the cortex, this is a gyri. In the gyri, the tumor has been there. So here the two nerves are there. So those nerves have to be preserved. So how do we do that? So we can exactly cut the middle part of the tumor and take it out. So that way it will not cause any major damage. So we have almost operated around 17 patients who are the mainly the almost we have operated two doctors, 17 patients who are 10 male and 7 females, and most of them are graduates. And you can see the kind of varied histopathology. 6 were GBMs, 5 were grade 2 astrocytomas, 3 were anaplastic astrocytomas, 2 were insular oligoastrocytomas, 1 was PXA or pleomorphic astrocytoma. We'll see one case. 23-year-old left-handed female dog. He's a doctor, and suddenly she had one episode of seizure. And she was having episodic headaches clinically. So fundus was showing papilledema. And there was no motor sensitivity. Neuropsychological emotional ability was not good. And as you can clearly see, this is the kind of tumor which we are able to clearly see in the right side, extending from anterior to the posterior, involving the whole this thing. And here again, we can clearly see the tumor has been extending from top to multiple gyri was stuck. Gyri started bulging. You can compare to see the right side versus left side, how much of significantly gyrus started thickening and all this. Tumor has gone down till the level of corpus callosum. The whole corpus callosum was also involved here. And here you can see the whole part of the tumor. The upper part was only significantly enhanced. The lower part of the tumor was not enhancing. As you can clearly see, this is again a kind of diffusion weighted diffuse tensor image. Here clearly you can see the tumor has damaged some of the fiber tracts here when compared to the other side. So this is the kind of image we get. So we have even done the functional mapping. This shows that the posterior part of the tumor has motor cortex. So if we unnecessarily, without operating, without patient being awake, if we go and operate, we are going to make her completely paralyzed on that side. So that we could avoid. And following which we have done the scan. Scan shows here the tumor has been excised. And here you can clearly see the whole tumor. We have gone to the level of corpus callosum and it has been completely excised. And you can clearly see the whole tumor has been taken out. And now this patient has been you can here also you can see the whole tumor has been taken from the posterior to the anterior. There is no more tumor left here. And here also you can clearly see from the top to bottom, we have gone to the level of corpus callosum. You can see the whole corpus callosum part, this tumor which is extending from above to below, has been taken out. And as you can see, this is almost like 2 years post-op, and there is no more tumor resection. After this, the patient has completed her MBA. She was in the final year. Now she's an anesthetist now. She studied, she completed her anesthesia. Now she is doing her routine practice. So this clearly shows that when we have a tumor and which we can clearly find out and excise, the patient will have good quality of life. Here again, another patient who had a tumor in the motor cortex area on the left side of the tumor. Here you can clearly see the whole tumor was going behind excised. And the lower part, you can see the whole tumor we have completely excised it. So this patient has been living comfortably since past 9 years. So that way, when we operate and do a proper job to the patient will have good quality of life. Another patient on the similar kind of tumor on the left side. As you can clearly see, you can see the date here 2013. We have operated in 2013, and gradually the tumor has not yet recurred as of now. That's what. So that way, patient has a quality of life almost like 11 years. The patient is being a good, having a good quality of life and able to lead a normal life. And another patient here, you can clearly see the tumor has been there and laterally the fibers which are there from anterior to posterior. So if you go from side, so that way we'll be damaging all the fibers tracts here. So that will cause more damage to the patient as these fiber tracts will be disconnected. Because the connections, these are the like wires. If you remove them, they will start having miscommunication or they will start losing communication with the rest of the brain. So in that way, that part of the brain becomes useless or functionless. So in that way, the capacity of the brain would be decreased. So in order to preserve all those things, we really need to know what kind of fiber tracts which are located in and around the tumor. That will help us, the surgeon, to find out plan the tract, the way we can do the things, the way we can plan in and around the tumor, the way we can achieve hemostasis, how much the tumor can be taken out, what are the structures which we have to preserve. So all these things we will be able to know it. So that way it will help us to map the surgical trajectory, and in that way the patient will have a better outcome. And post-operatively, we have completely excised the tumor. We have gone from above. If you see, we have not gone from the side, we have gone from above. And the whole lateral side of the tumor, the brain has been preserved, and the patient did not have any major neurological deficit. So in that way, most of the time, whenever we are operating limb, craniectomy, if at all, if it is available, the surgeon is able to do it, that should be done. Or the patient should be sent to a place where that kind of facility is there. Otherwise, it becomes very difficult. The patient will have a major deficit, the family will be devastated, and they will have more major complication. They cannot function. They'll become a burden for the family. The family has to spend a lot of money, and he becomes a burden for himself. The family, it's a kind of vicious circle. The family will be sent into, he will become a social burden even to the society. So the patient who is in a very young patient who has been a good quality of life, who has to lead a family life, who has a significant responsibility for the family, he should be always be given the best of the opportunities for him, because the first time is the best time and it is always the last time. We always believe that thing, because unless the patient is known to given a good chance to get him operated and get the things done, so it becomes very difficult for the other person, for the family to digest the fact that he will have a paralysis for the lifetime. So those things have you need to understand. And another, as we have seen the brain, let us see some of the spine. So a 40-year-old male patient who come to us with severe pain in the right upper limb, and he has right C6 radiculopathy. So we planned ECDF. Here you can see clearly in the MRI that the whole disc has come out, and the whole disc has come out and is lying in the theca sac, and it is causing compression of the cord. So because of which this has significantly caused patient pain, and he was not able to sleep, not able to stand anything. So following which we have done a simple anti-cervical discectomy and fusion. This is a simple operation. This case hardly takes around 1.5 to 2 hours, and the patient will have a small scar, which is around 2.5 to 3 centimeters, which is again subcutically cooled. At the end of usually 6 months or 1 year, patient we even will not, nobody will never know that he underwent surgery, because we usually give the incisions in the neck folds. So that way this will be completely gone. So this is how usually we enter from the anterior to posterior. Patients are very scared when we say that we operate from the front because they think that we are going to cut most of the blood vessels or the throat pipe or the tracheostomy kind of thing. He will not be able to breathe, many problems. But usually what we do is we usually go create a plane between the great vessels on the, this is the carotids and the esophagus tracheal on the medial side, carotid sheath on the left side. Gradually we go and dock at the level of longest colli muscles, and we can see the vertebral body. From there, we'll be able to see the disc level. And gradually, once we remove disc, we are going to put the cage. So that way, this is as simple surgery, and the surgery takes hardly 1.5 to 2 hours. And it will be done with the help of a microscope, drills, endoscopes. So these things will decrease the significant trauma to the structures, and this will help them to heal faster. And this is how usually it looks like. We have done a discectomy and we have done a cage placement, following which we have put the plates. These are usually titanium and the PEEK material. So they are very much comfortable for the patient and they will not cause any reactions. Even after surgery also, they can significantly easily go for future MRIs whenever they need. Because most of the time previously, some people, because of the cost factor or those, they used to use stainless steels. Now people use stopped. And if you have a good titanium metal and all those things, the patient will have less artifacts and he will not have a major trouble putting plates and screws, and he will easily comfortable in getting MRI in the future, because whenever future many problems can come, so he should not be deprived of the MRI in the future. And a 67-year-old male with progressive spastic quadriplegia. He came to us with, he was not able to walk. So when we have investigated, we found out in the MRI, as you can clearly see the upper part of the cervical spine, the lower part of the lower part of the cervical spine, you can clearly see the whole cord has been completely easily, there is no compression. But in the upper part, you can see from the level of 3, 4, 4, 5, 5, 6, multiple cord level compressions were there. And because of which the cord was getting compressed and he was not getting, he was becoming weak and he was not able to use, he was having multiple falls. So when we assessed him, he has significant spastic quadriplegia paralysis. So we explained him that no, the kind of surgery which you need is, sorry, we need to do a expose the posterior part of the spine. We need to do a laminectomy, and following we need to fix the spine. So the central part, once we remove the laminate, the central part is the dura. It is going to get a good space. So once we get a good space, gradually these parts will have a good comfortable area, and the patient will gradually recover. So this patient significantly recovered at the end of now. Usually we make them ambulatory on the next day or same day, depending on the requirement, how the patient, what kind of deficit he has. So usually at the end of 2 to 3 weeks, he has significant improvement, and the improvement continues till 1 year, because gradually these are nerves. We are trying to remove the extradural compression, and once the blood supply is restored, he will gradually, the nerves will start functioning again. The whole idea is not to make him further bad, because we sometimes, if the patient comes very delayed, they'll have cord within the cord, they have something called as myelomalacia. If that myelomalacia is there, the patient will have some kind of irreversible damage. But if we are able to handle it before, if we can do the things in a better way, so if the patient comes faster without delaying when he has a problem, thinking that something, if I go for surgery, many more complications will happen. The more problem happens if we don't go for surgery, because surgery, we know what we are trying to do. We are only trying to remove the compression of the cord. But if we just keep it without getting operated, the curve, spinal cord gets much more damage and he'll have much more problems in the future. So here again, as you can see here, uh, here a 40-year-old female was there who again had severe having neck pains on and off, and because of which the patient had multiple problems and she was not able to walk. So has, here you can clearly see behind C2, C3, C4, there's a large tumor coming from the C2 root, completely compressing the cord, damaging the bone, pushing the whole cord to the opposite side. So this she was having, and following which we have done another axials. Here you can clearly see the arrow mark, which is showing that the whole anterior part of the vertebral body has been destroyed and it is causing a significant cord compression. And there is good amount of damage to the spinal cord, and there is myelomalacia changes, and the whole vertebral artery has been pushed to one side. So looking at this, we have given option of surgery because patient was willing for surgery because she's not able to walk and she is having difficulty in holding her neck. So following which we have comfortably operated her, and you can clearly see the post-operative, she was able to move the hands and legs. And in that way, she has significantly improved, and she was very much happy when we operated her. So these are some of the cases which probably you need to understand. And I just give a brief view of the some of the brains and spines. So this is the kind of instruments we have. We also have Kino 900. We have navigation. We have QSAS drills. Most of the latest equipment which we have, we are also trying to acquire the exoscopes which were there. So that way we have almost all the facilities here in our hospital. So in that way it becomes easy, because once we have a good equipment, it becomes easy for us to give a kind of good outcome for the patient, because patient always comes to doctor to get better. And when we have the surgeon is as good as his instruments. We just cannot operate a patient with our hands. We need good techniques, and we have needed technology. So this technology also, nowadays people are accepting the fact that wherever technology is there, their only good work is going to happen. So the hospital is also planning to invest most of the things in this new technology, because that way it is going to help the patient as well. Once the patient gets better, he will have a good quality of life. He will not become a burden to the society, and he will be leading a good having a good quality of life, and that will help him to get better and lead a happy life. So we always try to do all these things. We always try to make the patient better. So that way, I will tell you to tell your patients or guide your patients in such a way that wherever the technologies are there, wherever the facilities are there, that way the patients should be guided. So in that way, they will take the benefit, and you will also be feeling better because you referred a patient somewhere where at least the new facilities are there, and where the technology is there, where the latest equipments have been used for the benefit of the patient. So in that way, it helps in overall. It will be beneficial to the entire society, for your own place, at the same time for the whole country. So in that way, I think that I will conclude my session, and I'll thank you for all your kind attention. Thank you.
Uh, thank you, Venugopal sir. It was like in a very small time, we have lived in a era. We can see all types of cases, but we have studied in neurosurgery. We found it to be difficult. Now we found that if these are in the able hands, in able technologies, we don't have a deficit.
Yes.
And we are happy. Most critical surgeries can be performed in the easiest way, and the ablution time is just 24 hours. Earlier, we used to see once operated, bedridden for months and years. Now we can see today you operate, and day after tomorrow you are discharged. Now there
Yes.
is no fear of doing any slip disc surgeries. There is no fear of doing any extrusion surgeries. There is no fear of doing myelopathic surgeries. No fear of removing excision of the tumor, that is the removal of the tumors. So we are very happy for that. Thank you so much, sir. Much obliged
Oh,
for your kind talk. We remain grateful to you. Thank you so much, sir.
thank you.
Thank you so much. Sir, there was a small talk of yours, sir. Yes, sir, will directly speak to you. There is a very good offer from Dr. Venugopal. All the good physiotherapists who are willing, who are BNYS, BAMS, who are really willing to work in acupuncture sciences, they can refer their patients to them and collaborate with sir. And by collaborating with sir, you have international publications. So when neurosurgery, acupuncture, physiotherapy, neuro recovery is done, I think we are to the next level. We are one level up of recovery. Now what we are looking is a good surgery and good outcome. We don't want a patient in present perfect, past, present perfect, continuous. That means you started with a deficit, You came with paralysis. You are in the stage of paralysis, and you continue with in the stage of paralysis. This paradigm has to be changed. Now, to change this paradigm, we need all of you to be united in one platform. The moment you unite in one platform, you see things changes. I'll show you my own academic achievement in just a few minutes, and I request all of you, please talk to Dr. I.P. Cherian. You will never get a chance. Somehow I pursued, sir, to give a talk on 10 o'clock. Now, again, because of my request, sir is giving a talk at 12:30. And I really believe that sir is like a father to so many people. And I feel that I am the adopted son of Dr. I. Cherian. Whatever I say, sir, please do it, and sir does it. You will never get an opportunity to hear such great people like Venugopal, Dr. E. Pawan Kumar, Dr. Karthik, and all these people will come. So I request you, please be there today. Use the best possibility of it. And I'll show you some of my videos right now. I'm sorry, my health is not very good because of my day-night work, day-night conversations, back-to-back workshops, back-to-back work, back-to-back hospital visits, 22 hours a day. My health has little deteriorated. But you will love to know that I have suffered from 8 heart attacks and I'm still healthy and a young man to work for 22 hours a day. And I'm very happy that you all are united here. And I'll show you some of my videos where sir said myelomyelitis cannot be recovered. I'll show you a patient who has been seen by 14 hospitals, both from 7 international and 7 national hospitals, and that of the state-of-art hospitals, where he was denied for surgery. The outcome of surgery was not good, and we recovered that patient in 28 days, and the treatment hour was only 105 hours. A patient who came on stretcher is walking without a stick. And that also a case of 2018, treated in 2024. We all thought this is not possible, but when we worked, we found it is possible. This is what I have learned. I share you small insights of the topic. Please carry on with the videos I've shared in you. Now you will be wonderful to see how we recovered myelomyelitis, compressive myelopathy, myelomyelitis, spinal cord injury, complete transaction injury being recovered. So to speak about myself, I have worked on spinal cord injury for around 30 years. And to my credit, I worked on 256 types of deficit. And you love to know, in these 256 types of deficits, I have recovered. We have a 80% success recovery rate. Maybe the patient has recovered by 60%, 80%, 90%. But then you must also appreciate and consider that the patient came to us after a stage where he cannot be recovered. He cannot be recovered. So you will see this is what has happened in myelopathy. And the myelopathy is a very complicated term. But when you enter the myelomyelitic change, you will see in the MRI, it is written permanent damage. So once this damage comes, the quality of life becomes dependent on wheelchair. And you can see how we start working from a patient from the stretcher to the walking level. And then you will see the life is changed. Together, we all have united only to say that what is not done in neurosurgery, what cannot be performed, what is a negative outcome can also be altered to a positive outcome. And this is what we call the paradigm shift, where neurosurgeons, neuroanesthetists, Ayurvedic doctors, homeopathy doctors, acupuncturists, physiotherapists, PNYS, all we have come together for only one mission. And this is why I created the Insights of Neurosurgery. And those who have attended the 3-day online workshop also, they will get a certificate from us about Insights of Neurosurgery. So we will request our coordinators to take the attendance of the people, those who are online, and we'll give you a workshop certificate of online certification. And the most beautiful part is that this is the first certification where you have been written the insights of neurosurgery, neurology, neuroanesthesia, orthopedic, neurology, and integration in neuroacupuncture. This is the first workshop in India conducted, and not only in India, conducted first time in the world. So we have participated, although in a precise way, but we have done a legendary work that in 3 days we have done a Herculean task. There is a saying, the Hercules was a person whose king used to say, you do the most difficult things. And this is why Dr. Cherian said to me, please, Shastri, go and spread the message of love, affection, and compassion. And this is why I am here, spreading through my works. In a very small and private hospital in Hyderabad, we have done most excellent work. We have recovered cases of transverse myelitis. We have recovered patients who have come from ICU. We have recovered patients from coma stages. And I'll try to see that we can have a live from our hospital maybe tomorrow, or we'll see some videos how we have recovered a very primary setup. But if your work is high, if your spirit is high, you can do miracles. And so we'll just have an insight of myelopathy. We'll have the investigation. We'll take a middle part and the last part. So each video will consist of only 3 minutes. Right? Thank you so much. Over to the videos. Come on. Can you hear me? Video? Can you hear the videos?
Occur in the thoracic spine. Myelopathy can be difficult to detect. Usually, it develops gradually in seniors with a loss of coordination, difficulty turning doorknobs, or problems navigating stairs. Sometimes, for example, after a neck injury, myelopathy may develop and worsen rapidly. Its symptoms depend on the location and severity of spinal cord compression.
You can see you stop 1 minute. Hello. Okay. Alright. So here you can see the MRI, and here you can see there is a myelomastic changes. And if you see one slide back, if you see the video, here you can see the myelomastic changes, and the radiologist has written this is a permanent damage. As per this MRI, the patient continues to be in the stage of quadriplegia, paraplegia, and entering to the stage of quadriplegia, and after 2 or 3 months or 5 months of his life, he'll be lifelong bedridden. And this is, you will see a patient, how he recovers from a stretcher and is walking. And then Dr. Venugopal said, once you have a myelomastia, it becomes difficult to recover. And that is where I started. When there is a permanent damage in the cord, you can see I've recovered that patient. And this is the MRI, and the radiologist has written permanent damage. You can see myelomastic permanent damage. Here you can see the MRI C67. There is a compression in the cord, and you can see the altered frequency, and you can see how the damages has happened. And this is a permanent damage where there is edema in the cord, and then the loss of tissue, and the reduced in the density of the spinal cord. And that results to what? You can see the cord is the extension of into the brain, and then you can see how it has damaged and altered the signals. And then you can see with the altered signals, there is a deficit, and the patient who was walking is on bedridden for his life. This is the prognosis. But if you walk in a determined way, if you walk in a better way, you can see these things can change, and life can definitely change. And that is why I say we shall overcome one day. Man mein hai vishwas, pura hai vishwas, hum honge kamyab ek din. And this video speaks of that determination that we can do today and tomorrow. And we can replicate it provided we are in one platform. Here you can see the weakness, the neurological findings. Yes, can carry on. Yes. Here you can see the term called myelomalacia. Go one stage slide previous. Yeah, you can see. Here you can see the myelomalacic changes. You can see that. I'm very sorry, I don't have a laptop, so it's very difficult for me to prepare all these slides. I just do what in a small time, whichever I get in my hospital, I just make some videos, and with this help of the video, my work is to bring awareness. And there you can see the myelomalacic changes, and there's a long disc protrusion in this case, extrusion, and because of this compression, you see a myelomalacic changes. Now in this myelomalacic changes, you have a permanent damage, and how you see a permanent damage recovers to a full recovery. And the patient was examined by 14 hospitals and more than 20 neurosurgeons, 10 orthopedic surgeons. And then everyone was saying there is a permanent damage. And I said, there is nothing called permanent. I always say, impossible says I am possible. And we'll explore this journey in just few minutes. My 120 hours of work, extraneous work of my team, you will see how we overcome in just 5 minutes. And you will see 120 hours of work, 28-hour days, day and night of work. You can see it in just 5 minutes. You will explore this journey. Over this. He is also having extrusion of disc at L4, L5, L5S1 level, L2, L3. So you can see caudal. He was also having incontinence of bowel bladder. Yani he could not feel bowel and bladder, and his incontinence was there. That means there is a feeling of bowel and bladder was absent. In the bowel, yeah, latrine or pesab ka feeling khatam ho chuka tha. He was having high constipancy, and then you can see he was having multiple discompression in the lower lobe. He was having high compression in the lower cervical spine, and now you can see the same person, the progressive stage, that I got a patient of deficit from the lumbar spine and cervical spine. Here you can see the Apollo Hospital doctor said immediate surgery is required for this case, and the outcome of this surgery is very poor. Is a poor prognosis, we say, because myelomalacia has occurred. So we cannot predict the. This is the MRI scan of the Dubai 2018, and you can see how progressively this became myelopathy. Carry on. Yeah, this is the scan, total scan of the patient in different T1, T2, DW1 images. Is a sagittal spine. You can see at various level, foraminal stenosis and canal stenosis can be noted in the cases. Here you can see extrusion and caudal migration is there. Caudal iguana compression is there. Here you can see the roots compression of the disc. Here you can see the different sagittal ridges. Therapy. 3 years, 20 years, according to 2018. Now, if you see he had a history of RTA, road traffic accident, and then you can see a substantial amount of damage you can see. Here you can see the C6 level 1, 2, 3, 4, 5, 6. So here you can see C6 level compressive myelopathy and myelomalacia you can note it here. You can see osteophyte complex space,
now you can see this 2016. Plasticity of the paraspinal muscle has been noted here. Patient is plasticity is 2018 has been noted in case. Here you can see plasticity of the paraspinal muscle noted in this case. You can see that this is some indication of what are the information?
Now, here you can see the arrival of the patient on wheelchair, and you can see the clonus. He is not able to stand at this situation. He is at the second level. Voice. Right here. You can see the person accompanying him is my physiotherapist, Dr. Ajay. Very young, dynamic leader. He is Dr. Navi. You can see with a very primary setup, we have done wonderful work. By now, we have recovered more than 200 cases of spinal cord injury in this small setup. Here you can see how he has improved gradually from the wheelchair to paraplegic walker to this walker. Here you can see him walking with the stick. And here you will see how I perform non-invasive brain stimulation in this patient.
We are dealing with a very critical case. Here come from Dubai, na? Dubai, Dubai. This case is having a long case of multiple disc degeneration and disc products at cervical. Then के काफी सारे disc बाहर आ चुके थे. Near prominent encroachments of line. But now the question was that कि patient का condition क्या था? There was a long standing case of cord compression. Long standing case of cord compression होने she turned up to compression myelopathy. After compressing of myelopathy, he again turned it to myelomyelin. Then the post-op position and surgery was planned with elongated cage and all these things was perfectomy was planned. But then he denied. Rest of the story he will say. This multiple ways of treatment. And you can see now the patient can walk. From a wheelchair to walking speech, you can obtain in this case. So, my problem is this one. Now
Here you can see. So here you can see I'm giving it's something like what the world has never seen before, that you are stimulating in the scalp without having a direct approach in the brain. यानी आप बिना brain को touch किए in a very safety procedure without having any damage, आप brain को approach किया, यहाँ stimulate किया, and by the real time process आपका 30 सेकंड पूरा होने से पहले you see the level of one level up in a myelomyelin case, and the patient after the procedure can immediately walk from the bed to the walking stage. In just 5 minutes, you can see a terrific change in the life of the patient. My cameraman is my Sandeep.
So you can see this patient was almost body seriously, and the right side was more weaker than the left one. Now, right side weak, huh? Right side. So now we will see multiple time NITS treatment. One is right now we are doing. And you can see the patient is after the treatment, will be able to walk on the treadmill. Yes.
कोई नहीं किया इंडिया में कोई नहीं किया सेवन इंडियन हॉस्पिटल एम्स टू एम्स एम्स सिटी एम्स कैडा लंबा thoracic ये परिफोर्मिस एमसी रिलीज करवा दो और ये C5 C6 C6 C7 You see, this is a real-time procedure.
Patient of South International Hospital, Princeton National Hospital from Dubai. He came on wheelchair, but recently he was walking on treadmill. This is the experience.
Now he is walking at the speed of 3.5 kilometers in the treadmill.
Our document evidence about the class will place our document evidence and how the patient was carried out. It's comprehensive myelopathy or myelopathy disease. Myelopathy is not myelopathy. I am not proud of the people who started the
You can see the most important achievement of this patient is that now he the most important achievement of this patient now is what? He can walk 3.5 kilometers for 30 minutes in this treadmill. You see? But the patient can now walk at the speed of 3.5 kilometers. How many? 3.5. Yes. Now you can see a permanent damage, quadriplegia, 24 hours. No, you can see the infrastructure of the hospital. And he was denied by 2 AIMS, AIMS Trichy, AIMS Karnataka, AIMS Hyderabad, Apollo Chennai, 3 more international hospitals, and 7 international. So 7 state-of-the-art hospital in India, and 7 international hospital, and 2 AIMS. So he has been denied surgery by 14 hospitals. How many? 14.
So you can see he's walking comfortably on treadmill at the speed of 1 kilometer.
Very good.
one company, one vaccine, or spine, mental was I want to go something else. Second, one policy and games, or games and one hospital and one, two hospitals together and
कौन सा गया बताइए वीडियो लो बाबा सेशन क्यों सेकंड ये तो हो गया ना ये वाला वही तो है ये केस और देखो उसमें दूसरा वीडियो दिया So now I'll show you a video of spinal cord injury, a girl who came from So here you will see another case. Says a case of spinal cord injury, quadriplegia, 22-year girl with elongated case and decompression has been done. And here you can see the recovery of the child. So here you can see the post-surgical X-ray. She had a road traffic accident. And then you can see in just less than a month, she is walking and mobilized. She was totally bedridden and she was shifted from Mumbai. Here you can see the compressive myelopathy. Here you can see at C5, C6 level. This is the assessment of the patient. Here you can see C5C6 surgery was done. Very elongated case and corpectomy.
This NK Shastri from European Hospital, Hyderabad. A patient with another critical case which has come from Mumbai and in a very short span of time you can say good recovery. The patient is जिसको cervical cord injury हुआ था, you can see SC6 is terminal where the RTA injury or complication injury हुआ. And the patient has suffered from RTA injury. This injury was because of the reaction. Thereafter she was admitted and corpectomy was done. SC6 is terminal. And you can see expandable cage has been treated here. So the patient came in at a very difficult state and she was very depressed. Not only depressed, but also very insecure. That's why cervical cord injury is a situation it was very difficult for the patient to sustain because he believes that he cannot recover. He has to recover. The patient will recover contact of the that means we understand the patient will not recover in a very short span of time. Patient will recover daily of that. But it is very different here. You can see like
Here you will see that what we are doing in Hyderabad, same thing we are doing here. And you are saying that we are recovering a spinal cord injury patient over there also, over here. Yesterday we treated one Parkinson patient. Now today you see he is having 50% improvement in Parkinson. Me, Dr. Vati and me, we are working together. And this is another case who came to Gurgaon on stretcher, was not able to move from stretcher. And now the patient. So now you can see a case of transaction injury, complete spinal cord injury, patient is able to walk with support. This is another medical miracle which we have performed in Hyderabad. And this is what we say, अगर मन में तमन्ना हो तो कौन कहता आसमां में छेद नहीं होते, एक पत्थर उठा के तकदीर से तो फिर तो आसमां भी छेद हो जाता है. So you will see what is said, impossible is possible. Here he is treated in AIMS. The surgery was done in AIMS, New Delhi. The best institute of India has done this surgery. One of the best neurosurgeons has done surgery. And now you can see post-recovery of this patient. Over to you.
सर आवाज नहीं आ रही है।
worked on 256 sites of deficit. Now I'm going to present a case. A patient came from Bangalore, treated with complicated brain surgery, and is bedridden, an orphan. He did not have money to pay me, and from my own pocket I spent it, and I recovered him in just 2 sessions. And this video is that demarcation that a patient came with wheelchair, a grade 4 spasticity, and recovered on the bed. So at 12:30 you will meet, after 15 minutes you will meet Dr. I.P. Cherian. So after 15 minutes, you will see the most legendary neurosurgeon and my teacher, Dr. I.P. Cherian. And then his student, Dr. Nikunj Jain, all will be there online today. You have a very busy online session. One after another speakers will be speaking. And then Dr. Mead also will be speaking. And Dr. Vati also will be speaking. So here you can see a complete compressive keratotomy and keratoplasty and 4 years on bed.
Yeah, they are very complicated cases. We are getting one of them is this case. If you see this case, अगर इन केस को देखते तो इसमें
सर आवाज नहीं आ रही है सर।
So here I am performing non-invasive brain stimulation. Tomorrow you will be seeing, this is also live navigation. You can see I have done a live navigation procedure, but we have no access to the brain directly. So you can see tomorrow NTMS versus dry needle based stimulation.
and the special brain stimulation.
Here you can see NTMS versus dry needle stimulation. Tomorrow, Dr. Farah will say what is the importance of NTMS in therapeutic and treatment part. And after 15 minutes, Dr. I.P. Cherian will be there. And then after that, Dr. Nikunj will be there. Dr. Karthik will be there. So parallelly, you will hear from a lot of speakers. And in the evening and night, you will be with us. We'll be teaching you from your place what is direct cortical stimulation and direct access to the brain damage. And there you can see how a neuro recovery can be done. So you can see the same type of brain mapping at different angles we have placed the needles. And here you can see the 1 or 2 more cases we will see after Dr. I.P. Cherian's talk. Then you will see Dr. Nikunj. Then you will see Dr. Karthik. Then you will hear back Dr. Mihir, Dr. Vati. Tomorrow you will hear Dr. from Zimbabwe, Dr. from Germany. And then you will see a beautiful workshop, a neurosurgery in combination with orthopedic neurology, with neuroanesthesia and neuroacupuncture. 4 platforms brought together, and in the beautiful way, we are coming to a concluding him that in just 3 days, we have covered a Herculean task of this job. So here you can see, it's a keratotomy mark. You can see 4-year-old, this case was there. He was unable to walk. Grade 4 spasticity is so poor that I have paid this. In the hospital, I am not the owner of the hospital. So I have paid his room rent. I have paid his room charges, fooding charges, treatment charges from my own pocket. And now you can see the result of the same day stimulation and same day recovery. It may not be achieved in all the cases. Let us not be anxious of achieving those results in a single day, but let us give the time to recover. But wherever is required, we do our best to recover the patient on the table. And you can see the recovery of the patient on the table in this case.
So is the double case now see.
You can see the real-time assets. You see the power. You got 2 plus plus, now you see it's 5. You see, in a brain operated cases, where there is a mass loss of tissue damage,
How much power? आगे से नहीं पता था आगे से तो कुछ like which is much prayer हो गया ना the power is done. The power is done. Are you ready? You have this much power at home? No. Now you can see everything.
एंटी में 2 करोड़ का मैं अभी एंटी में से काम चल रहा है. It's very difficult mapping. Now Dr. I.P. Cherian will be talking, and I stop my conversation. You are connecting to Dr. I.P. Cherian. Please participate as much as you can. Put the link in the group. Ask everyone to talk to Dr. I.P. Cherian. You will never get a chance to talk to Dr. I.P. Cherian in your life. So please take the benefit of this workshop. Dr. I.P. Cherian is here. I request you to please talk to him. Email. Forward the click करते जाते Sir, I forwarded the link in the WhatsApp, sir. Should I forward in the email, sir? सर मेरे को ईमेल सर दे दो मैं अभी आपको ईमेल करता सर डॉक्टर वाती आईपी इज कमिंग नाउ हाँ हम आपको इंट्रोड्यूस कराता मैं आ जाओ इधर आ जाओ मैं आप लोग दोनों को इंट्रोड्यूस कराता आईपी से मैं सहाना का जूनियर बोल के सहाना का कोलिक बोल के अभी आप लोग पूछता ना ये सहाना का बॉस है दीदी लिंक राजू चेरिया एक मिनट ये कहाँ है राजू चेरिया हमको आज पता चला सर का दूसरा नाम राजू है क्या बात है फेक नेम राजू है नेपाली नेम सर लिख के देना हो सकता है oblige sir oblige PLIG LIG oblige sir done thank you आप लोग अब चैलेंज मेंटेन करना तो ट्राई पीस है
Hello. Hello.
Morning, sir.
Good morning. Can you hear me? Can you hear me?
Yes, sir. Yes, sir. Yes, sir. We can hear you, sir. We are very grateful that the most legendary neurosurgeon of the century is with us, Dr. I.P. Cherian, my father, come my mentor, come my teacher. A person who has taught me how to live life. I never thought I live a life, but the person I was saying myself, I was a black and white TV, and sir made me a 5G Android TV. I was roaming in the round, but sir brought me from the Supreme Court. He brought me to the field of neuroscience. This is the achievement of this person. He is a person. In Hindi, we will say, sir, once. Kabir Das has written something for you, a person like you. एक लोहा मंदिर माही और एक बदित पढ़ो पारस को अवगुण नहीं देखत कंचन करत करो प्रभु मेरे अवगुण चित न धरो This is a very wise saying. It is said, someone asked me, sir, what is Dr. I.P. Cherian? I said, Dr. I.P. Cherian is a person like a paras, एक पारस पत्थर है सर. And more than that, उसके लिए कहा गया है, कबीरदास ने लिखा सर आपके लिए, क्या? Years back, Kabirdas thought I.P. Cherian will come and it should be defined in this word. Ek loha mandir mahi. With iron is in the temple and the same iron is in the butcher's house. कंच पारस गुण अवगुण नहीं देखा. पारस पत्थर जो है सर वो अवगुण भी नहीं देखता और गुण भी नहीं देखता. और कंचन करत खरो प्रभु मेरे अवगुण चित न धरो. समदर्शी है नाम तिहारो चाहे तो पार करो प्रभु मेरे अवगुण चित न धरो. So this much only I can say, sir. We are those people who don't deserve to be on the feet of yourself. A person who has changed the neurosurgery, a person who imagines something beyond the centuries, a person who has changed and transformed entire karate. Entire karate has come to the world map today. No, what to say? A Bhakti of Shiva, Triguna, a person who knows Hindu mythology more than any of the Hindus, who speaks about Ved, Puran, a person who speaks about neurosurgery, and he is the one who brings Shiva into neurosurgery and neurosurgery into Shiva, where nothing is high, where nothing is low, where everything is same. And that is what Sir says, Shivoham, Shivoham, na ankara na puram, na vedya na patam, na chitto na saram, ham gunmasmi, ham Shivoham, Shivoham. And that is by Dr. I.P. Cherian. He says, I am Shivoham, Shivoham, Shivoham. How about you, sir?
Thank you, Shastriji. Great opportunity for me to be here, to be talking to you. Can you hear me properly? Can you all hear me?
Yes, sir.
Yes, sir.
Yes, sir, we can hear you very clearly.
Yes, sir. Nice hearing your voice. Such a great person. Thank you very much for giving this opportunity, both to Mr. Shastri and yourself also. Thank you very much, sir.
Yeah. So I will first show you what is it that we do. I would not bore you with the details, but when we started in many years back, we thought that neurosurgery is still primitive. We are doing neurosurgery with a lot of primitive things. So we wanted to change that a bit. I'm going to show you, I'm just going to share my screen and show you what we do. Can you see my screen?
Yes, sir. Yes.
Okay, so this is what you are seeing right now is the first exoscope in the world that we thought we will design, and we had a shoestring budget. We didn't have any money with us, so only $10,000 we had, and we designed this. And this was done in Spain in the year 2014 to 2016. So you can see how this is. Instead of a usual microscope, we designed this. This could actually work in tandem. It had a camera and an endoscope, and it was programmed to see and bring whatever is in the field to the center. So at that time, all these things never existed. First of all, exoscope was just an idea. Now we have a lot of exoscopes in the market. We have designed a few exoscope ourselves. But this is the first exoscope, and you see that pattern, it's bringing it to the center by itself. You can see the code running in the background. So even today's exoscopes, they are not capable of doing it. This is my engineer, Eduardo. And with head movements, you can move the robot to where to look. So we went ahead, and after that, we designed EOS. EOS is the Esculap exoscope. And we realized that it is a $1 million. So we wanted to design our own exoscope in India, which is 1/10 that money and which is equally good. In fact, I would say more neurosurgeons are comfortable with this because it works more like a microscope, and the shift is much more easier. We have designed the robotic part of it. Is also, the prototype is ready now. It has zooms of up to 100, and it is named after my elder daughter, Sanma. Sanma is the company who makes it, and Sanma is a South Indian based company. They have now business all over the world. They are exporting and having contacts all over the world now. And this is the endoscopic holder named after my second daughter. So it holds the endoscope, and earlier people used to hold the endoscope. Now this can hold the endoscope and give you freedom, complete freedom. So this is all designed in India. It's all in the markets. Now, this is something that we do for brain strokes with the exoscope. Supposing anybody had a stroke, Shastriji will tell you that the stroke has an umbra which you cannot save, and the stroke also has a penumbra. The penumbra region you can save. So saving the penumbra region, you need to give that penumbra region more blood. So what you do is you take a vessel from outside the brain, like superficial temporal artery, and then you put it inside. So that is what I'm going to show you. So you can see what I'm going to show you. It's a superficial temporal artery taken from the scalp. That's the artery. And you're going to bypass, that's the artery, under very high zoom. And you're going to bypass it. You know about cardiac bypass, everybody knows. But brain bypass is very rare. We've been doing and teaching brain bypass all over the world. And these are all instruments designed by us. This is called the Cherian line of instruments. And we do this bypass at extremely high zoom, ultra micro neurosurgery. So we put about, this is a 0.6 millimeter vessel, the size of your hair. And we are going to bypass this so that this patient's condition becomes much more better, even if the carotid is closed off. So for strokes, we do this. It is a game changer, and we hope that it will become, now in United States and Japan, it's become a norm, but many other parts of the world, it's still not a norm. So we hope to change that. So you see 5 switches here, 5 switches on this side, and 1 switches on the heel and 2 end. So an outside vessel is sutured into an inside vessel, 0.6 to 0.7 millimeters. So this is another case where there's a cyst in front of the brainstem and the cervicomedullary junction. No bone work. We can do it without any bone work, just minimally invasive. So that's why we call it the future. So here we have opened only the ligaments, soft tissue and the ligaments, opened the dura anterior, going anterior to the dura under high magnification, taking out the cyst, going and completely taking out the cyst. Absolutely no bone work. You can see the vertebral artery there. This is another pica aneurysm. This is an aneurysm. So one of our specialties is aneurysm. You can see how clear and how magnified. These are the vasa nervorum. You see it so clearly with this kind of zoom. Usually people all over the world magnify up to around 20 to 30, we magnify over 50. That is why we call it ultra micro neurosurgery. We started this term. So only thing is you have to be like an elite athlete when you do ultra micro neurosurgery, because even small tremor can be magnified 50 times. So no coffee, no tea, excellent fitness. You need to have the correct state of mind, meditation. So all this has to be brought into picture. So that is how the aneurysm is. And finally, when you put a clip on the aneurysm, that is how you're going to put a clip on. That is how the clip is on now. So this is the work we do with aneurysms. This is a tumor where small, very small axis is used. So a 2.5 centimeter craniotomy is used to take a tumor zone which is on both sides of the corpus callosum. So the endoscope is, this is the exoscope 3D, and you can see the endoscope going in. With the endoscope, you can see what the exoscope cannot see. Here is what you cannot see, and I'm taking out that part of the tumor. This is an epidermoid. You cannot pull without seeing. So you can see these vessels there. So these vessels, you have to dissect it off the tumor and then very gently take it out. So you can see that. And you can see a small craniotomy, minimally invasive approaches. And this is my theater where we have the country's only exoscope. It was Asia's first exoscope. And also the endoscope holder that we designed, that's the second prototype. This is the endoscope holder, probably the only one in the world. And you can see this is the endoscope holding facility. That's the endoscope which is being held. Escolab helped us for this. These are our innovations which are published in different textbooks. This is the UNESCO's anatomy, digital anatomy textbooks published by Springer. So this is what we are doing. It's our concept. I never patented it. I don't believe in patenting anything. So this is the concept of hyperscope that I started first. And then we are using a HoloLens. Now we use an Apple Share Pro to operate. This is the concept that we take a CT scan, reconstruct the CT scan and put it on to the real field so that the surgeon knows exactly what they are doing. So this is an aneurysm CT scan reconstruction, and this is how it is put onto the real field so that you know where you need to clip. This is something that I started, cystonostomy, 120-year-old surgery for trauma. We changed it with much better results. Now it is done in all over the world. 80 surgeons from 80 countries do it now. Thema has brought out the book on this. And along with it, we also described how the brain is cooled and clean. In fact, very interesting that the brain is cooled when you breathe. You know, when you breathe, like the yoga breathing, you breathe, the brain is actually cooled. So that is why you can see this is the tree of life, and that is Ajna. That is why I put it on my cover page. This book has been released now for neurosurgeons. This is a picture of our OT. It's one of the most advanced OTs in the world. There are 3 OTs. This is the main OT. It has got an intra-op CT. The CT comes on a rail. When I want, it comes on a rails. You can see that's a CT that comes on a rail. And this is how we operate. This is the exoscope robot. It's one of the most advanced theaters in the world. So, as Shastriji always says, our mind is the greatest lab. So you have to learn imagination. You have to learn to be open with your mind. You have to learn to leave comfort zones and old teachings and learn to make paradigm shifts. And you have to dream so big that others should laugh at you. Okay? They should think you're crazy. That is how you can make changes. So when you corner a Harley Davidson, you should not look at the obstacles. You should look at only whatever path is there. And that's how you can you cannot see any obstacles. People say, I struggled, there are so many obstacles. But if you don't see any obstacles, it's easy, to go on your path. And this is our life beyond. So always remember, neurosurgery is only one part of my life. And when I do a lot of other things, I learn from all that. My courage derives from all that. And as always, you can see, when we do things which are beyond neurosurgery, we go ahead and we learn and derive courage. And always remember, a bird doesn't sit on a branch trusting the branch. The bird trusts its wings, and therefore the bird can sit on the branch. And all of you who are practitioners, you should know everything about lots of other things as well. So it is just not practice. So you should know. I mean, I would probably talk about Shiva some other time, but this is what we stand for, and this is what we do in Karad. 80% of our work, we are probably one of the largest charity hospitals for neurosurgery in India. We have 200 beds, 80% of it is charitable, so probably that makes it more than AIMS or Vellore or any other institute. So all of these patients who come to us, we can do it at charitable rates. And we are not looking for money. We are looking for the best treatment for the poorest of patients. And we'll keep promoting that. We have patients from all over the world. They pay for my poorer patients. So I think that'll be enough for today. Thank you very much. And if anybody has any questions, I'll be more than happy to answer.
Sir, I still remember two things, how God plans things. I'll tell how certain things I do not know, but how God make things happen, we never know. Sir was saying to Farah, you have to teach Shastri what is NTCM, and sir told me in the car that Farah will negotiate about NTCM, and we are very happy that tomorrow Farah is giving a talk on NTCM, and it is only just because of sir that just because of sir we are having this. So, sir, Dr. Mihir Ranware would like to ask you a question, sir. Dr. Sir, can you hear me, sir? IP, sir?
Yes, I can hear you.
Dr. Mihir will like to speak to you. And sir, I'd like to introduce you to the colleague of Dr. Sahana in Chhattisgarh. Is Dr. Wati, is a neuroanesthetist who has worked with Dr. Sahana in Chhattisgarh.
Debu is my boy. He's a fantastic surgeon, and he's working with me now. Great to see you.
Sir, myself, Dr. Chatrapal Bhatti. I have done neuroanesthesia from Chitra, sir.
I see. Great to see you.
And I have also done fellowship in pain management. So I am practicing pain and neuroanesthesia and other things.
Excellent.
I have worked with Sahana for 2-3 years.
I see. Sahana, Debu is right now working with us. And
I conference.
Yeah, so Debu is a fantastic surgeon, and we are very happy to have him here.
Yeah, very good person also.
Yes.
Okay, thank you, sir.
Sir, he is Dr. Mihir, is from Mumbai, and he is a very great fan of you, sir. And he knows you since I know you. Through me, he knows you. He has performed more than 4,000
hip and knee replacement
surgeries.
But now I'm into regenerative orthopedics.
Oh,
He is
excellent.
working on steps.
Maybe I should see you, because I have a ACL rupture and I have minimal osteoarthritis in my knee. So maybe I should see you sometime.
Sir, I wanted to ask you one question. In case of a transected cord, when we repair cord, like if we suture it, so how much is role of stem cells in the repair of the regeneration of the cord cells, and how much does it help the recovery?
Yeah, so my friends in China, especially Professor Guo Yi, who's the deputy director, one of the most reputed stem cell centers in the world, they've had excellent results with dogs and even monkeys now, with transected cord and stem cell injections. And they have seen how the neuronal growth happens and how these they recover up to 70% of their functions. Now, in human trials, this has not been uh, very well reproduced, primarily because of problems with permissions and other things, and the studies lacking, uh, you know, ethical code of conducts, and all these are very difficult to get. So that's the reason. I think what can be done in canines and monkeys can be finally reproduced into the human system as well. I'm sure a lot of people are trying, but I'm not an expert on this. But from what I know, I think it'll be only 5 to 10 years. I mean, I see Shastriji raising his hand. 5 to 10 years before there will be major breakthroughs in this.
Sir, I like to bring a point to your insight that I have done stem cell therapy in more than 18,000 cases, out of which 300 cases are of stem cell therapy. And I was showing them the video, and you have seen the videos of myelomyelitic changes from wheelchair, stretcher to walking. And in this, we have repeated the procedure. Monthly, we have done stem cells 4 times in the patient, and we have injected the stem cell near the facets and in the epidural space. And there was no negative outcome. And we have replicated the procedures from last 6 years, and we got very good outcome. And some patients have started walking independently in those cases where there is acute myelomyelitic changes from last 6 years. So,
Yes.
sir, I found that these cases with stem cell therapy is just nothing but stem cell therapy, collecting the bone marrow and making it what you call a PRP based and injecting it. And there is no side effect, sir. I'm very confident that there is no side effect and immediate results.
Yeah, excellent. So, yeah, tell me.
In ligament injuries and joints, we are using Placentrex as a growth factor. So, do you suggest, sir, adding Placentrex to stem cell therapy will enhance the effect in any way as a growth factor?
I really wouldn't know about that. I haven't done any work on that, so I wouldn't really know about this. But from what I believe, all those mystic enigmas surrounding stem cells and all are gone now. The G0 phase, any cell can go to G0. So it is a lot of other things that affect these things, and what Shastriji says, a lot of people may not understand what he says, but if you take bone marrow, which is rich in stem cells, and earlier they used to take the olfactory neuronal cells, but now bone marrow, even fat, even blood, they have stem cells. They can go to G0 phase. So I'm not an expert. I really wouldn't be able to answer many questions on that. And I haven't, to be very frank, I have never used stem cell therapies in my clinical practice. But I'm sure the future holds a lot of promise for stem cells. I may want to study more about that.
Sir, before leaving, can you give a small brief about how did you overcome cystonostomy and how cystonostomy is going to change the world? Why is a Nobel laureate paper, sir? How new cystonostomy from Kocher, 1905, the Kocher to Nedgard from 2012 paper for Boston University to cooling and cleaning of the mind to cystonostomy, how things have changed. So a small brief on this topic will be very happy. When Dr. Ait speaks, Let the children's demand, sir.
Acha. So the largest problem in the neurosurgical world is trauma anywhere in the world, because 5/6 of the world is developing world, and there the biggest problem is neurotrauma. So the present surgery right now, what is being done in most places is that they take a large bone flap out and they keep it in the abdomen, or they keep it in the freezer or something. Can you hear me? Can you hear me?
Loud and clear from Nigeria. I
Oh.
Yes, sir.
So generally what they do is decompressive hemicraniectomy, which they take a large part of bone and keep it in the abdomen. This is because of the brain swelling. And we, in 2007, by quite an accident, we figured out that opening the cisterns in the base of the brain helps to relieve that kind of swelling, and we don't have to take the bone out. Plus, we found out that it's much more physiological when you do that. It is much more physiological and produces much less deficits compared to a decompressive hemicraniectomy. So, but the problem is there's a lot of vested interests, because the people who do the decompressive, they have 2 surgeries. And plus, when you put $1,000 bone flap, there are companies which benefit from that. And mostly nobody asks for a guarantee in a patient who is undergoing a decompressive. So we started a campaign against it. It was very difficult for us. Even now, it's very difficult. We had the WFNS president at that time to declare that it is equal to, it's as good as, first cystonostomy is as good as decompressive. But while it was way better, because we were outlawed, we had them to first declare that it is as good as decompressive, and then finally now superiority trials are going on. In the world, there is only one way to get your things done, and that's by trials. So all the trials are happening now, and people who are doing it, they clearly know. We were called for Michael Schumacher's case, and we had gone to Switzerland, and the surgeon there came here, learned cystonostomy with us, started the trial in Europe. That was in 2015, almost 10 years back. And now all the young neurosurgeons swear by cystonostomy. After that, we also realized that the CSF in the base of the brain is used for cleaning and cooling as well. Even before Nedagard and group proposed, we had written about it, but we had no basic science. We were in Nepal at that time. And even in India, basic science research facilities are much less. So we went ahead and we hypothesized that the brain is cooled by the sinuses. When you take in a breath like that, there are small openings to the sinus. Anybody who understands physics will know the Bernoulli's principle. And whenever there is a small opening, the velocity there increases, and thereby it actually produces evaporations like a fan on the sinuses lined with mucosa. So that what happens is these sinuses, they start evaporating the fluid from their mucosa, and they cool. And all the sinuses are very beautifully aligned around the suprasellar cistern, which is a collection of CSF. And the suprasellar cistern cools. And from the suprasellar cistern, there are a lot of vessels going into the brain. And these vessels are pulsating. And around them, there is a space called Virchow-Robin space. When you pulsate something, and there is a space around, this fluid is usually by Archimedes' screw principle, the cooled CSF actually goes into the brain. And that's the most beautiful way that, the brain is cooled and clean. So we described that way back 10 years back. And now that has got a lot of implications in neurodegenerative disorders and things like that. So other than proposing about changing the neurotrauma scene, we also proposed how CSF cools the brain. Now we are started ultra microneurocity. We are designing new instruments and new techniques and new approaches for neurosurgery. So if I can do this, I'm sure each of you can innovate, and like what Shastriji is doing, innovate and keep on doing new things and change the world. I thank you for the time that you have allotted me. Thank you very much.
Devo Maheshwara Guru Sakshat Param Definitely Guru Gana Jnana Mulam Guru Bhakti Sudha Mulam Guru Padam Mantra Mulam Guru Vakyam Moksha Mulam Guru Kipa. Then you said me one thing in my life, don't charge for teaching, and that gave me a lot of inspiration. Today I work 22 hours because of your inspiration. Day I work for my hospital and night I work for the students. Whatever savings I make and I teach them for free in the world. And that is Sir's inspiration. Sir said, never charge for teaching. Knowledge is free. Never charge 1 rupee in your pocket. And Shastri, if you are able to do it, you will understand the love of God in your heart. And I really say you, sir, mantra moolam gurur vakyam and moksha moolam guru kipa. Today now I understand what is God, what is teacher, and what is love. And today I say, sir, very beautifully, I suffered 8 heart attacks and now I'm easily ready to suffer 4 or 5 more heart attacks because everything you taught is that be positive in every negative adverse circumstances. Now, when you take the heart attack so beautifully, you realize the love of Shiva. And when you realize the love of Shiva, you understand Samadhi. And now I say that, sir, only 8 heart attacks I had. I'm ready to suffer 12 more heart attacks. And that is Dr. I.P. Cherian. It takes you from 1 heart attack to 20 heart attacks. And then you say, I'm having a Limca book of record in heart attacks. I'm having major heart attacks and working 22 hours a day, 24 hours a day without rest. And now that this is the spirit, the students are tired, the teacher is continued from 48 hours, non-stop conversation, sir. It's only your presence. I tell you what you say in our Veda, mantra moolam gurur vakyam or moksha moolam guru kripa. When you understand the word of your teacher, you just said Farah, you said Shastri to Farah, and me, you told me at your Farah. And you see, tomorrow Farah is giving the first talk on NTCM in the world, in our class in India. And this is the first batch in India to understand NTCM. We all know about RTCM, but just because you said only one word, Farah to me and Shastri to Farah. And now we are together, sir. And we are teaching this world what is NTCM. And sir, we will be happy that all the students will come to Karat to learn this NTCM. We'll like to, on behalf of you, I've invited every one of them to come to Karat and see what is real neurosurgery, what is real recovery, and how to recover a patient on the table. This is what I believe. And most important thing of your achievement is that you are believing of epileptic surgeries. Young children who are overloaded with Tigritol, who are overloaded with lithium, who are overloaded with all this, having destroying their gut and liver. And then, sir, today is one of the most beautiful day also, sir. 3 generations coming together. Lakshmi has spoken today. Nikunj is speaking after you. So you mentored Lakshmi, Lakshmi mentored Nikunj. So 3 generations, and I am mentored by Nikunj. So 4 generations, great-grandfather, father, son, and the grandson today is giving the talk on the same day. And I don't know how to express this beauty that 4 generations in one talk today, sir.
Thank you, Shastriji. Only thing I would have to, if there is any parting message before I leave, you remember Om Purnamataha Purnamitaha. That is complete, this is complete. Purnat Purnamudachyate. Completeness arises from only completeness. And if you take completeness away from completeness, completeness only remains. So we are all complete in our own ways. Okay. There is nobody who is more complete or less complete. All of us are complete. Okay. As we remember that, thank you very much. I'll carry on. Okay, see you guys.
Thank you very much. Thank you very much. Thank you,
Thank you.
Sastriji. Very good, beautiful class. Thank you, Sastriji, for linking us up with IP Cherian and the knowledge you're giving free to everybody. May Allah bless your efforts, Sastriji.
Thank you. Thank you so much, Walid.
Thank you, Dr. Sastry. Thank you, Dr. Cherian. And thanks, everybody. Thank you.
See you.
I'll be happy that you will stay for 10 or 20 more minutes. The third generation is coming. The father has come. The son has come. His son is coming. And then I am coming. The fourth generation of neurosurgery are sitting together. In CMC, there is a mentoring situation. So, IP mentored Lakshminath. Lakshminath mentored Nikunj. And Nikunj mentored me. So they are fourth generation in the same loop, on the same talk. And it was so happy. Sir forgot about the talk, in the morning. But then I said, sir, you have a talk. I forgot. Sir, you come, we'll give the talk. But then how did you manage? Sir, I took your talk from YouTube and I managed it. And then you see the simplicity of this man. Such a legendary neurosurgeon. Even the World Federation of Neurosurgeons. I like to show you the photos of the what? Of the conference. That the best neurosurgeon of the world has come to Karad. And Karad is just a place of 20 kilometers. It is one town of Gurgaon. Not even Gurgaon. You can just say Karad finishes in 20 kilometers. And then this person has bought the entire neurosurgery, like a cysternostome in the world. He has opened the cisterns and he has reduced the negative pressure. Now, if you come with a traumatic brain injury and you have a edema in the brain, right? You have edema, swelling inside the brain with negative shift. This person says, I can recover a patient, what? And we can do the surgery and on third day, the patient goes back on walking. We have seen that in our life. And that is what inspires me. When I came with the dry needle on the scalp, every neurosurgeon, every neurologist, every physiotherapist in the world was laughing at me. Well, what bloody you are doing? You don't have access to the brain. You don't have access to anything. But I had a faith in the Bible. I had the faith in Gita. Gita says, in Haryana, there is a very beautiful word. When everyone says negative, you say one word in Haryana, Dekhi jayegi. And I interpret it from the word Haryana, from Kamanyavadikaraste, Mahafalisu Kadachana, means you do your work and you don't forget about the fruit. But in Haryana, it is a very beautiful saying, Dekhi jayegi. And this Dekhi jayegi inspired me so many ways. Now I say, I have done this. Now you prove me I am wrong. After doing 5 life cases, you cannot say M.K. Shastri is wrong. You cannot say now that M.K. Shastri is wrong. I stand with only 1 rupee needle. And then I say, and yesterday I proved in the workshop that we can recover a patient below 1 second. At night, 2 o'clock, there is evidence, there are videos where we have said we can recover pain below 1 second. We had to minus seconds. We had to minus seconds for pressing the button, but we have proved that below 1 second, patient's pain can be relieved. You all believe it is not possible because you never studied brain. But we studied brain as what? So, we will show you one more thing, the magic of the brain. And by 1:30, you have to be with Dr. Nikunj. Then you have to be with Dr. Karthik. Then you have to be with Dr. Avinash. Then you have to be with Dr. What do you call it? Dr. Pawan Kumar. Pawan Kumar is another neurosurgeon. And then you will be with Dr. Avinash. Then you will be with Dr. Vilas. So all the talks, we thought it to be a workshop, but it became a conference. That's the magic of life. We never thought everyone will come. Everything was hodgepodge here yesterday. I said, what did I do? But you see, when the thoughts are clear, when the leadership is fine, everything which was wrong today, yesterday, everything has come to its slope. Dr. Vatki has taken the OPD, Dr. Mir has taken the counseling, May is giving a talk, and we will also show you the power of the brain. So now you can see how brain is powerful. It can control 1000 degrees centigrade, and you can see a person is not burned. So now you will come to a video called The Fire Yogi. I like to show you this video, and it will change your paradigm shift that yes, brain is very powerful. It's not just a game. God has given immense power. Only you have to explore it. So here you will see the fire